Okay, Joey. Thanks so much for sending over your algorithm. Yeah, I endorse it. I think this is good. I think I've seen something similar from maybe it was Davies historically, who's also kind of triaged the testing and the discharge criteria based off the patient's preoccupation status and what they're trying to get back to. So yeah, I endorse these or this dichotomy. We'll talk a little bit here. I'll give you some slight recommendations on maybe some of the criteria, but I think it would be most helpful just to kind of talk through the check sheet that you had sent out. So I left some comments in it as well, and we'll just kind of step through it. So yeah, I mean, all the precautions is going to be either surgeon or patient based, but I agree with all the ones, everything pretty much on the first page. As we get down into phase 1 through 3, or months 1 through 3, phase 1. So my comments are just those things that I would do differently or that I do differently, but not to say like one is right or otherwise. So when we're doing straight leg raise testing, I will also, the other things that I've utilized, so I use a standardized tempo of 40 beats per minute. So I flex their opposing leg up to about 45 degrees, and I put my hand over top, and they have to hit my hand tick, 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 tick. So they hit my hand, and they also hit the table. 40 beats per minute is what I found to be adequate for most people. If they really have a long leg, maybe you have to dampen that down even further so it's appropriate. But otherwise, and I found that to be really good. I will also add in that I also use M trigger or some type of biofeedback to watch their sustained contraction, because even though what I have found is that even though they don't have an extension lag, the quad gives out halfway through. They're still able to accomplish the task, but they're not able to lock out the neuromuscular drive for the endurance of the test. I use 20. I've heard up to 30 repetitions, but I will say that I've captured people. I've started to identify deficits after repetition 10, so that may be a consideration. When discharging the assistive device or the or the brace, a couple things that I do here. So when it says normal gait mechanics, I'll often have them go over cones. So if we look here, so this is like criteria for full weight bearing, but again, I utilize it with both the brace as well as the crutches. Predominantly, they're coming off the crutches first. So the couple things when we look at the assessment, and then we can look at the criteria. So your normal gait analysis, we have that. I use that as well, walking analysis. So I just have some numerical values, and I'll just put either someone on a treadmill or I'll just film them walking across the clinic, capturing these, and I'll use technique. And I'm in the process for trying to get a markerless-based motion capture system that will take these markers for me. The other thing that I do that further challenges the gait is I'll use a cone walking task. So 60 degree, again, they have to hit the same markers from a range of motion. The difference is they have to do a single leg balance on the outside foot. So when the involved leg, so they'll go over the cones with the involved leg going over the cones, and then they'll also do it backward, they'll turn around, do it again, but now their involved limb is going, their uninvolved limb is going over the cones, and they're having to balance on their involved side, and they're doing so for 3 seconds, because I coach this to be quite mechanical, where it's they're really exaggerating the motions. I think it allows me to better discern any discrepancies there from side to side and from what I otherwise would expect. I also use age predicted norms rather than like the 30 seconds, and this is with eyes closed rather than just eyes open. So I'll do eyes open first, like for instance here. I'll use that 30 seconds, but then I'll also go eyes closed. And then the other thing that I do that's a little bit different is that I use 100% weight bearing times 15 repetitions per lower extremity. So you set up two cones, about 2 feet apart, and you can normalize it to their body size or anthropometric measurements. I don't. I just use 2 feet, and they have to go at 30 beats per minute. So it's like, and it's a lateral step. So it's tick, tick, tick. It's a modified version of what is the lateral leap and catch for like the flea. And this really just allows them to not only assume weight onto the limb, pause for a moment, but then also transfer or have a propulsive force off the involved limb. Otherwise, it is pretty much the same as your progression or what you've outlined. The other thing that I will also do is I'll have like a assisted device weaning program, and so I guess both of these are a little bit more conservative. I do have a 1 week one that I'll give out. And this just allows for homeostasis of the knee to be maintained while they transition to the full weight bearing. So every 48 hours, or in this case 72 hours, they're they're off the crutch, the assisted device, or if they're wearing a boot, not in the knee instance, but in other instances, they're essentially you're out of it for 1 hour in the morning, 1 hour in the afternoon, and then you're adding an hour to each bookend of the day until you're up to 8 hours. And I found that to be really fine for most folks. Again, maybe it's more conservative than most. If the person is doing really well and their swelling's already controlled as is, then usually I may expedite this to a 3 to 7 day time point. And that gets to what I wrote in here, like 78 to 72 hours. So it's all fine and good if they can stand up and go through their clinic routine or their day with full weight bearing. But usually I say, yeah, we can't really fully discharge the crutch until you're 72 hours out and the knee is still in a homeostasis. Then when discharging the brace, so again, I would have more repetitions, use M trigger or biofeedback if possible and available, and I would also standardize the tempo. Single leg balance with slight knee bend, yep, I agree with that. Same with the mini squats as well. The one thing that I will add here is a feed forward perturbation, because really what I care about most is that can they stabilize when they land on the limb. So I'll have them close their eyes and standing on their uninvolved leg, and then I'll do it again on their standing on their involved leg, and then I'll have them close their eyes and I'll just push them over in multiple different planes of motion, and they'll have to regain their balance with either a stepping reaction or some other balance reaction depending on the extent of the perturbation. And if you don't feel comfortable pushing people, then sometimes I'll just use a Swiss ball and I'll just like bump up into them. That's another way that I do it. And again, that's not, I don't know, I guess it's more qualitative, but it does give me further confidence that they can assume an unexpected perturbation and catch themselves either on the involved limb or the uninvolved limb, depending on which one they're weight bearing on. Yeah, this all looks good. I do use the full wide balance testing versus just the anterior reach, which we kind of discussed the other day, because it gives me the composite score, which I think is a more robust risk stratification measurement rather than just the asymmetry from side to side. And then when it gets to running, so the one thing, I think this is like from, we have a lot of similarities in our practice, right? Because I learned under you. But I will say that I've done away with the 10 consecutive single leg squats. I just didn't think that it was rigorous enough or applicable enough to what I'm going to be asking the person to do. So I've gone to 80 single leg squats to 45 degrees at 40 RPMs for 2 minutes. With the trunk, knee, and pelvis femur angle less than 10 degrees deviation. So same criteria as your time lateral step down. The reason why I do it for the duration that I show there is because that's comparable to the phase 1 walking and jogging for 1/10 of a mile, presumably still using like the Brigham Women's. I've modified it a little bit, but the Brigham Women's Hospital progression, phase 1, phase 2, and so on, or the different levels of returning to running. I think similar to you and Jason had presented during residency. Yeah, there it is. Yep. So similar to this. All right. Okay, we have similar criteria here as well for the progression of sports training, which I presume to be like kind of unrestricted or plyometric based training. So the only slight difference is that, let's see. So I have and I think it comes from the same article that you were using above, the Wilk and Arrigo article. I think it's like 2018 or something like that. So let's see. So for our criteria when we're looking at high-level plyometrics or sports-specific training, so yes, they've already done their running. I guess this is the one element that would do is like 1.5 times body weight. And I've used the alternative as a leg press just because when you squat 1.5 times body weight, there's also like the technical skill of actually squatting well versus the leg press just kind of allows someone to just push brute strength and knowing what the limb tolerance is. And then also having the faster rate. So 60% body weight, which obviously maybe goes hand in hand with your 30% earlier in your progression. And maybe you do this with equal weight distribution with your body track system, and then 5 reps per 5 seconds, so it's relatively rapid. Okay, and then when it returns to be it contact or non-contact sports, a couple of considerations would be, I love that you have the single leg vertical hop. I think that that's one tool or one test that is really a necessity and relatively easy to do with current technology, be it the phone app or otherwise. So that's good. I would say that breaking out of just sagittal plane hop tests may be of consideration. And then additionally, I would maybe have some, I guess you have them here, is like the running, sprinting, or beyond just the vertical hop test, if possible, having some other form of rate of force development. But maybe it's a reactive, it's like RSI. Gosh, I forget what it's actually called, but it's an index that's used based off like the drop vertical jump. Reactive strength index, yes, RSI. That would be another consideration there of what you potentially could use beyond just like the vertical hop height in and of itself. And then another interesting test that I believe Dustin Grooms is looking at. So I've also been interested in trying to incorporate what is the neurocognitive element within testing. So the way that it works is you stand on your single limb and you close your eyes and you're on your uninvolved limb and you jump, start uninvolved limb, eyes open, 3 maximal hops consecutively. Do the same thing on the involved limb, 3 maximal vertical hop tests on the spot. And that really just kind of orients the person. Then you do the same test and you have them close their eyes, and their goal is not only to jump as high as they can, but also to kind of come back within the same footprint. So Dustin Grooms out of the Ohio State University, he looks at less than 10% decrement in loss of height versus essentially eyes open, eyes closed, and the amount of displacement from where they started. So he's found that drastically correlates with some of the functional MRI stuff that they're looking at with those individuals that have more of a visual motor strategy development rather than their innate sensory motor strategy, which I found interesting and relatively clinically friendly. If you're not going to measure like the formalize the measurement of the displacement, if nothing else, it's good for a qualitative assessment, because I know what he has stated is that just people can't do it. Another one that he's done to capture that, and I found it to be relatively clinical friendly, is, and I haven't yet implemented it, is if you take either an Oculus, which is like a virtual reality headset, or if you just go on Amazon, you type in smartphone headset, right? So you can put the smartphone right up to someone's eyes, so that's all that they see, and you put them on the Empire State Building or some extravagantly high place, and have them stand on a 6-inch box and have them like drop down and land. So they land single leg on their uninvolved 3 times, and you're looking at your landing error scoring system, or LESS, that's been described multiple times over in regards to ACL prediction. And they're not jumping back up. It's not a counter movement jump. It's just like, hey, not only just with visual occlusion, but with a visual perturbation where you have to disregard your visual system, can you attend to your sensory motor system as you land off a 6-inch box, even though it appears that you're on the Empire State Building or walking a tightrope or something like that. But anyways, I think this is the place where rehab is going, and where some of this neurocognitive testing is going, and I think we should be ahead of the curve. So those would be some of the additional recommendations. In regards to, I did just holler at the nonlinear hop tests. So one thing I did want to share, so let's see, nonlinear hop tests. So I'm in the process of publishing a book chapter actually on the return to sport testing for the knee, specifically just the testing element, not the rehab. And a couple of things that I put in here. So single limb vertical jump, and I'll look at the 3 trial average, and I would also recommend taking the less score. And so you're looking at limb symmetry index and their power output, but as well as their quality. That's the landing error scoring system. And then for the sagittal hops test, you've got them. The ones that I would also recommend is your medial rotational hop, your single lateral hop, your medial triple hop, and your timed speedy hop test. The time speedy hop test, I think it requires some equipment, actually, if I'm not mistaken. But these other 3 work really well. Another thing that I have yet to test out, but I'm really anxious to do so, is that what they show on the sagittal plane hop tests is that 87%, on average, 87% of the propulsive force comes from the rest of the limb, the ankle and the hip, where the knee only contributes 13%. But the braking force is substantially higher knee demand. What I'm interested in, because it captures both the quad propulsive force as well as the visual element, is a reverse hop test. And so instead of just doing your single hop forward for distance, you have them hop back. And if you, I think that the best option, or the better option, I should say, is test their single limb hop forward, take 75% of that, put a piece of tape down, have them jump forward to 75% of their maximal distance, and then have them immediately spring back and see what the displacement is from the piece of tape to where they actually land. Because that really puts on the braking force, which is the predominant function of the quadricep and the knee when they're doing their cutting-based tasks. And then it also gives you that power aspect, that reactive power aspect of how far backwards they're going to be jumping. So those would be my recommendations there. And then the final point that you have here, so isometric, or 60% for non-contact hamstring, the quad ratio. So my one question was, what are the angles that you're testing this at? Because I imagine that your hamstring to quad ratio would be different based upon the knee angle. Maybe fixed at 90 degrees for hamstrings and quads gets people to the 60%. but I don't know. So that was just more of a question than anything else. And then the other thing that I've been playing around with, rather than just the hamstring, the quad ratio, is something called the functional ratio. Maybe you're privy to this already, and you just don't have the equipment. I don't know, but I found it pretty cool, and I've definitely been using this as discharge criteria for my proximal high hamstring individuals. So the way that it works is you use the isokinetic machine. Oh gosh. Yes, you use the isokinetic machine, and you test them concentrically, both hamstrings and quads, at 30 degrees per second. And then you test them eccentrically at 30 degrees per second for both the hamstrings and the quads. And then you also look at their concentric quad and hamstring contraction at 240 degrees per second. And that gives you a ratio. So what is their eccentric hamstring to their concentric quad? And that should be greater than 1.4. And the rationale here for why they do this is that's how these muscles typically function within sporting events or high sprinting, if you will. So as you rapidly accelerate, or you can imagine someone sprinting, is that your hamstring has to eccentrically contract forcefully, and then your quad's going through a rapid concentric moment. And so this ratio has shown to be a little bit more robust rather than just the hamstrings to quad ratio. But I will say that the hamstring to quad ratio is current standards, if you will, for sure. Okay. And then what you can also see here, and maybe just take a screenshot. So then I have ranges beyond just your 3.0 Newton meter per kilogram. You can easily convert this to your foot pounds. But it's slightly different for females than males, and this is a little bit higher than what is previously described at the 3.0 that we discussed. And this has been described at 60 degrees of knee flexion, so that may also be different than what you're looking for if you guys are fixed at 90 degrees of flexion. But yeah, those are the big takeaways or my initial pieces of feedback. Otherwise, it looks super comprehensive. Thanks so much for sharing.